Hello everybody and welcome to our module on heart sounds. Let's start by talking about S1 and S2. When you listen to the chest of a patient with a stethoscope, you will hear two heart sounds, often referred to as the lub-dub of the heart beating, and those two heart sounds are called S1 and S2. These are the two normal heart sounds. Each of the two normal heart sounds has two components. One comes from the left-sided valves closing, the aortic and the mitral, and the other component comes from the right-sided valves closing, the tricuspid and the pulmonic. If you look at the top right side of the screen here, the first heart sound, S1, is made by the mitral and tricuspid valves closing when the right and left ventricles contract during systole. The second heart sound, S2, occurs because of sound made when the aortic valve and pulmonic valve close. Sometimes you can hear with your ear the two components of each heart sound, other times you cannot. S1 is usually single. The two components, the mitral valve and the tricuspid valve closure, are usually close together, not separated by much time, so it's often very hard to distinguish the two separate sounds with your ear. S2 can often be split. The two components of S2, the closure of the aortic and pulmonic valves, are often far enough separated by time so that they're audible with your ear. Not only can S2 be split, but the splitting often varies with the respiratory cycle. Sometimes S2 is split during inspiration, sometimes during exhalation, and sometimes during all phases of the respiratory cycle. And that pattern of S2 splitting, how it changes with the respiratory cycle, can tell you something about the underlying condition of the heart, whether it's normal or whether certain pathologic conditions are present. And that's what we're going to talk about in the next few slides. The first type of splitting of the second heart sound during the respiratory cycle that we'll talk about is called physiologic S2 splitting. This is a normal finding that you will hear in patients who have normal hearts. If you look at my drawings on the screen here, when patients are exhaling and blowing air out of their lungs, the two components of S1 and the two components of S2 are very close together, and you can't separate them with your ear. Both heart sounds, S1 and S2, are going to sound single and not split. During inspiration, however, the two components of S2 move further apart, and you can often hear this with your ear, and S2 will become split. So this is called physiologic splitting. It's splitting of the second heart sound that occurs with inspiration. The reason this happens is because when you take in a breath of air, there's more venous return that has to flow through your right ventricle before the pulmonic valve can close. This delays the closure of P2, which is the pulmonic valve component of the second heart sound, by just a little bit, about 40 to 60 milliseconds, and this is usually enough for you to hear it splitting with your ear. So the bottom line is that S2 will go from single to split with inspiration. This is normal physiologic S2 splitting. I'll play you an example of this now. The first three beats are during exhalation when S2 is single, and then the beats after that are during inspiration when S2 splits. Persistent splitting of the second heart sound is abnormal. This occurs in patients who have a right bundle branch block or pulmonary hypertension or something that delays closure of the pulmonic valve both during exhalation and inspiration. If we look at our little diagram again, in the case of persistent S2 splitting, S2 is split during exhalation and then it splits a little further during inspiration, but the bottom line is it's persistently split through all phases of the respiratory cycle. And this happens when something is causing the pulmonic valve closure to be delayed. It could be a right bundle branch block, it could be pulmonary hypertension. And the way to remember this is that persistent, the R in persistent is for right-sided delay. Fixed splitting of the second heart sound is also abnormal. This is the classic auscultatory finding in a patient with an atrial septal defect. Let's look at our diagram once again. In the case of fixed splitting, the second heart sound is widely split during exhalation and remains split to the same degree during inspiration. And the reason this happens is because in patients with ASD, there's more flow across the right side of the heart, and that causes the closure of the pulmonic valve to be delayed during all phases of the respiratory cycle, exhalation and inspiration. So the two classic findings of patients with atrial septal defects are listed on the slide here. It's a fixed split of the second heart sound and a systolic ejection murmur at the left sternal border. This is caused by high flow across the pulmonic valve. And then the final form of S2 splitting is called paradoxical. This happens whenever there is delayed closure of the aortic valve. So again, let's look at our diagram. In paradoxical S2 splitting, what happens is the second heart sound is split during exhalation because something has delayed closure of the aortic valve. During inspiration, the two components of the second heart sound get closer together, and S2 will sound single. So this is the reverse of the normal physiologic splitting. You have splitting during exhalation and a single S2 during inspiration. So what are some things that can cause delayed closure of the aortic valve and give you paradoxical splitting of the second heart sound? Well, there are electrical causes like a left bundle branch block, or if patients have a right ventricular pacing lead that's causing their heart to be paced from the right ventricle. These electrical causes delay LV activation and contraction, and therefore the closure of the aortic valve will be delayed, and that causes paradoxical splitting of S2. There are also mechanical causes of delayed closure of the aortic valve. All of these are things that delay the left ventricular outflow, and therefore it takes longer for blood to get out of the left ventricle and longer for the aortic valve to close. So these can be things like left ventricular systolic failure, aortic stenosis, or hypertrophic cardiomyopathy. And the way to remember this is that paradoxical ends in L, and that L is for some left-sided delay in blood flowing out of the heart and closure of the aortic valve. The second component of the second heart sound is caused by closure of the pulmonic valve. And this component is sometimes called P2 because it's the pulmonary component of the second heart sound. And this gets loud when patients have pulmonary hypertension. And it's super high yield to know this for your board exams. When the pressures in the pulmonary artery are high, this causes forceful closure of the pulmonic valve and makes the second heart sound pulmonary component, the P2 component, loud. Normally you don't hear P2 at the apex of the heart. If you hear it here, it's loud. So if they describe P2 being audible at the cardiac apex, that means it's loud. And anytime they describe this finding in a board question, they're telling you the patient has some cause of pulmonary hypertension. That could be lung disease, it could be left-sided heart failure. You don't know what the cause is, but pulmonary hypertension is present. Now let's talk about S3 and S4. These are generally pathologic or abnormal heart sounds, not usually present in normal patients. Both of these are diastolic heart sounds, so remember that systole occurs between S1 and S2, diastole occurs between S2 and the next S1, and so it's during that diastolic period where you will hear S3 and S4. You may be wondering how you can distinguish an S4 and S3 from a split heart sound. And the reason is that the pitch is different. These are very low pitch sounds. They're heard best with the bell of the stethoscope. S3 occurs early in diastole. It's called an early filling sound because the diastolic period is when the left ventricle is filling. And S4 occurs late in diastole. It's called a late filling sound. And if you look at the bottom of the screen, S3 basically occurs right after S2, and S4 basically occurs just before S1. Let's talk about S3 first. S3 is a classic auscultatory finding in patients who are in acute heart failure. When patients are in acute heart failure, their left atrial pressure is high. This causes a forceful push of blood into the left ventricle during early diastole, and that blood slams into the wall of the left ventricle and generates the S3 sound. In clinical studies, the presence of an S3 has been associated with high left atrial pressure and high left ventricular end diastolic pressure, and both of these pressures go up in patients in acute heart failure. This is a very specific sign of high left atrial pressure. Many patients do not have it, but when they do have it, the presence of an S3 almost always indicates high left atrial pressure. Now, there are a couple of special caveats to S3. S3 can be heard in normal hearts among young patients, especially children or patients under 30, and among women who are pregnant, like this woman on the screen here. These patients have very vigorous LV relaxation, and that essentially sucks blood into the left ventricle from the left atrium, causing it to slam into the wall and make an S3. So in this case, the S3 is not being caused by high left atrial pressure. An S3 sound can sometimes be difficult to hear when the patient is seated upright on the examining table. You should be aware that S3 is classically loudest in the left lateral decubitus position. This is an example of a patient in the left lateral decubitus position, and if you examine them in this position, you can often hear an S3 when you otherwise cannot. Also, S3s are classically loudest at the apex of the heart. And I'll play you an example of an S3 now. The way many people recognize an S3 is by listening for the word Kentucky. So Ken is the S1 and Tucky is the S2 and the S3 together. Kentucky, Kentucky. That's what heart sounds sound like with an S3 present. An S4 is heard in patients who have a stiff left ventricle. So you can hear this in patients who have long-standing hypertension and left ventricular hypertrophy. You can hear it in patients who have hypertrophic cardiomyopathy. You can also hear it among patients with diastolic heart failure. It's caused by rapid late filling of the left ventricle due to the atrial kick, and this is important to remember. You will not hear an S4 in patients with atrial fibrillation. This is an example of atrial fibrillation shown on the screen here. These patients lose their atrial kick. They do not have normal, vigorous left atrial contraction, and therefore they cannot have an S4. And I'll play you an example of an S4 now, and many people recognize an S4 by thinking of the word Tennessee. The tenna is the S4 and the S1, and the C is the S2. So Tennessee, Tennessee. Let's talk about systolic clicks. Systolic clicks are sounds that sound like a click. That's how they get their name, and they occur in systole. And there are two types of systolic clicks, each associated with different pathology. An ejection click is a click that occurs early in systole, and by early in systole, I mean that you can hear the click before you feel the patient's carotid pulse if you are palpating the neck. The classic cause of an ejection click is a bicuspid aortic valve, although you can also see it in pulmonic stenosis. Second type of click is called a non-ejection click. These clicks occur later in systole. They occur after the carotid pulse, and the classic cause of a non-ejection click is mitral valve prolapse. So that's a nice segue into mitral valve prolapse. Mitral valve prolapse is a billowing of the mitral valve leaflets above the annulus. Let's look at this drawing I have on the screen here. At the top is an example of a normal mitral valve, and you can see that the leaflets come together and are relatively flat. In a patient with mitral valve prolapse, the leaflets billow up into the atria. Basically, the leaflets have become stretched, and that leads to the findings of mitral valve prolapse. In general, this is a benign condition. The only exception is that it can lead to mitral regurgitation, and sometimes that mitral regurgitation can be so severe that patients require surgery. As we just talked about on the last slide, it causes a systolic click. And just an aside here, lots of students confuse the systolic click of mitral valve prolapse with the opening snap of mitral stenosis. Don't do that. The opening snap of mitral stenosis is a diastolic sound. The click of mitral valve prolapse is a systolic sound. And the two demographics in which mitral valve prolapse is common are young women and patients with Marfan syndrome. And it's high yield to know this for your boards. It's almost always going to be one of these two groups of patients if they describe MVP. And finally, let's talk about the murmur of mitral valve prolapse. So as we've already discussed, mitral valve prolapse involves a click that occurs in systole. Following that, there is usually the murmur of mitral regurgitation because most patients with mitral valve prolapse have some degree of mitral regurgitation. So I'm going to play you an example of the murmur of mitral valve prolapse now. This is a challenging murmur to identify. I'm going to first play 3 beats of just the murmur of mitral regurgitation, and then I will add in the click so that you can hear the click and the murmur together. And then finally, most murmurs decrease in intensity with the Valsalva maneuver. To perform the Valsalva maneuver, you ask the patient to bear down like they are having a bowel movement, or you can also ask them to blow out with their mouth closed. Either of these things is going to cause the Valsalva maneuver to occur, which decreases venous return to the heart, and that decreases flow through the heart, and most murmurs get quieter with less flow. One exception to that rule of thumb is the murmur of mitral valve prolapse. In general, the intensity of the murmur increases with Valsalva, and this is very unusual. Only 2 murmurs get louder with Valsalva. Those are the murmur of mitral valve prolapse and also the murmur associated with hypertrophic cardiomyopathy. And that concludes our module on heart sounds.